Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content.
Welcome back to the 8 Minute Rule. I got with me here Mark and Drew, ready to hit on a couple topics again for you guys. So, first things first, nice little icebreaker question here. We all have them, our snacks that may be hidden and hopefully not in between patients or during treating patients that we're eating, but they're sitting in our desk to make our way back to. So, Mark, what is your snack that's sitting in your desk right now?
I don't snack. I have zero snacks at my desk. I eat my lunch, and that is the last thing that I eat before dinner.
That's a lame answer, but fair. What about you, Drew?
I have a bag of pistachios that has been there for a while, and I should eat them. The reason I don't is because I walk by sweets and candy and pick up those. So that's the problem.
Turn those down.
You know what? I don't bring any snacks personally, but there may be snacks that are brought into the clinic that I will have some of.
Biggest challenge to eating well is patients love to bring us stuff, and that looks different all across the board. Absolutely. All right, so without further ado, last week we focused primarily on mostly chronic issues and looking how an objective evaluation was going to dig in that. And so this week we want to shift a little bit more to the acute and subacute group and just kind of some pearls, what you guys see and what you're thinking through as that patient walks in the door. Drew, why don't you give me a little bit of rundown, more of the acute patient. You've worked through their subjective, gotten a good history, and now you're veering into your objective measures. What are the things you really want to key in and lock in on and keep in regard with that more acute and subacute patient?
Yeah, and I'm going to use the term mechanical, so differentiating from that central nosoplastic type pain. And my primary goal is to identify the primary pain generator. Is this a cervical thing? Is this a shoulder thing? Is this an elbow thing? And then getting potentially even more specific, differentiating between extra-articular, contractile, non-contractile type things, and trying to hone in on what do I think is the primary thing and where I'm going to get the most bang for my buck in regards to treatment.
All right, so I like that. So really, now you're kind of trying to funnel into, you've done a lot of your evaluation from the subjective standpoint. It needs to be focused here, right? You really want to drive your testing with treatment in mind, it sounds like, as you're trying to work through that.
Yes, and a big piece of that is probably differentiating each thing. So looking at how can I modify body position, joint position, stresses on different tissues when they're having their symptoms, when you find whatever it is that reproduces that.
Awesome. Great. Mark, what you got for us? What's going through your head as that acute, subacute patient comes in and you're working to the objective measures now?
Yeah, I think, Drew obviously had some good thoughts there. I think I'll take it a little different direction and talk about how we can essentially avoid biases or try to make sure that, when a patient walks in and they say, hey, I've got like lateral hip pain, my first thought is like, oh, it's like the greater trochanteric pain syndrome. Okay, maybe it is. Or it could be that it's actually a labral issue. It could be that it's a referral from the spine. And it's very easy to anchor on something that seems very likely and not do your due diligence to rule down competing hypotheses. It's a lot easier to do a lot of testing to essentially prove yourself right than it is to do some testing to try to prove yourself wrong. And so when I'm going into an objective exam, your subjective, if done well, should really hone you into really 2 or 3 hypotheses that you're going to want to test out. And you need to make sure that you're doing a due diligence of testing those things out without bias, essentially. Because that'll ultimately lead you down the right track. Now, to Drew's point, you want to try to identify the primary pain generator that doesn't mean that, like, just because they have primary hip generator extra-articular hip, that doesn't mean that the low back isn't also involved, or intra-articular hip, or something else. But you kind of hone in, and in fellowship they actually make us put a percent likelihood that it is this condition, or once you get to your treatment hypothesis, put, well, I think 80% of their symptoms are generated from this particular thing, and then 5% is poor sleep, 5% is their low back, filling in the remaining percentiles.
Yes, I love the percentage thing, because as you have somebody who's probably more acute, more irritable, it's going to be slightly more difficult to identify with super high confidence, because everything might be flared up a little bit. That's going to be those painful inflammatory mediators that's going to sensitize everything. And as much as you can, still try to identify, do I think this is a lumbar thing? How much is contributing to it? Like, it's in the environment of, it's a contributing factor, but not the main thing. Regional interdependence stuff. So like in those situations, it's, hey, it might hurt when you're side bending to the right. Is that because you're adding stress to the hip abductors and you're putting more, or if you're going to the right, you're decreasing the amount of demand on the hip abductor and putting hopefully a little less tension potentially on the tendon. So if you're going to the right and it's significantly increasing that pain, my thought is maybe there's a little bit more lumbar thing going on here, because you're kind of compressing, closing down on those set joints, less space, so it's probably a little more lumbar. You're getting up over, which is kind of a reverse Trendelenburg. And so if that decreases it, now I'm like, okay, this might be a little bit more of the lumbar thing. How can I maybe totally take that out and prop their foot up on a stool, right? So you take all the weight off of it and you do that same motion with the lumbar spine, and does that change it? So working on differentiating between those, that sometimes it's not a specific test that we usually do, but really trying to dig back and say, how can I modify the factors in order to put more stress on one and less stress on the other in order to have higher confidence. Sometimes you can do it really well. Sometimes that's really difficult.
Yeah, I think that's well said. I mean, obviously, special testing can give us a ton of value in terms of working in a lot of different ranges. But what you guys are saying, I think, roundabout, is you obviously got to get to the asterisk sign. It's going to be a little bit easier to find likely than that chronic pain patient that's coming in with them having a little more acute, subacute. And then you're trying to work into the test retest, right? Like, to be able to have that light bulb moment to, like, okay, we did this, and then now it changes. And I think goes without saying that if you don't at least create their familiar pain within your objective measure, you're going to have a hard time getting anywhere, because it's very vague. Within that same regard, obviously with the irritable patient, sometimes there's just things that kind of need to calm down, and so you may not get that massive light bulb moment. For you guys, what pearls do you have? What kind of piece of advice do you have when thinking through at what point, as you're working through your objective measures, do you have enough to where you need to go ahead and dig into treatment? Like, how do you balance that line of over-testing versus testing and getting enough information that you can now run with?
The beauty of that, Jordan, and the reason that we're safe, I think, from a lot of AI, is that it is different for every single person that comes in the clinic. If my evaluation, if I have a lumbar evaluation that I take all my patients through that have low back pain, I am missing the mark with them. Every single person is a little bit different. Every single person has different severity and irritability, different goals, all of those things. So to your question, this is the PT school answer that works for everything. It depends. But the truth of it is, it takes as much as it needs to take. In someone that is highly severe and irritable, I'm not going to be doing a ton of testing before I find something that hopefully decreases their symptoms, and then I may go right into that. For someone that's lower severity and irritability, I may have to really dig to find their symptoms. I want to be able to reproduce their symptoms, and so I may have to work really hard to do that, depending on how low the severity and irritability is. And one tidbit that I have incorporated since going through fellowship is, in people that have lower or moderate severity and irritability, before I actually even get into trial treatment, I'll re-rack. And retest my asterisks because I've just moved them around in a ton of different ways, and it may have made their symptoms better. It may have made them worse, but I won't know that until I go and test it again.
That was well said. To put it into like a one sentence thing, my general rule of that treatment threshold is when another test won't give me any more information than beginning treatment. And then, like Mark said, making sure you're using that test, treat, retest, which is still an assessment, but it's hopefully going to be making a bigger change, an overall change that we can take in a treatment direction. And then the key on that side is do the test, treat, retest after each thing. I was talking to some mentees of mine, a resident and a newer grad, and they were saying that they were giving me the presentation of the patient. Here's all the things. And I was like, okay, what did you do for treatment? Because they had their main hypothesis. And they said, well, I did this, 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 and this. One was a soft tissue. One was a shoulder thing, some postural stuff. And one was like a thoracic self-mobilization. And I was like, so what did each one do? And they were like, I don't know. Altogether, it was better. And I'm like, okay, great. But what is the main primary thing? So, there are multiple things that they see. And I think the hard part is when in school, we're often taught, you see an impairment, you address it. You see an impairment, you address it without necessarily retesting everything immediately after. So we don't know how much it changed. And I agree with see an impairment and test it and treat it. Make sure you also test it, because then we can get much more laser focused on what is the main thing, what makes the biggest difference. Let's clear that up. And let's maybe not move on before we clear that up. Either they get the full range, whatever it is back that we're testing, or symptoms are gone, and then we can look at the next thing.
Sorry, I was muted during that time. So biggest takeaway, at least from what we're hearing, is obviously test enough. What's an encouragement to all of us, as Mark said, that I believe we're fairly AI proof if you're doing a quality evaluation, right? Because the objective measure is going to be retesting what's in front of you and what changed from that. And I think that's a big important thing for us to be able to utilize, and it just shows how important it is to have quality in what you're doing. Good stuff on that. Appreciate it, fellas, and we will look forward to talking again next week. All right.